I'm Dr. Matt Russell. I'm the clinical director of geriatrics and the medical director of the geriatric medicine clinic here at Massachusetts General Hospital. I want to extend a warm holiday welcome to our patients and families, and also from our practice, but also from other practices in the MGH system. I'm sure I speak for all of us when I say that it would be lovely if COVID would finally relegate itself to the history books, and that this has been going on and we're all maybe just a little bit bedraggled. That being said, we have a really great program today to address the current state of things, the state of the science, how we can all position ourselves to be able to enjoy a wonderful holiday season. So with that, I'd like to introduce our moderator, Susan Edgman-Levitan, the Executive Director of the John D. Stokel Center for Primary Care Innovation at Massachusetts General Hospital. Susan.
Thank you, Dr. Russell. So we're so happy you can join us today. And before we get started, I just want to share a few of our housekeeping rules. So first of all, everyone is muted to eliminate any background noise, because we really want everybody to be able to hear our speakers. If you want to view the speaker on your full screen, you can go up to the right-hand corner, the upper right-hand corner, and you can either click on speaker view, or you can go to the gallery view that will let you see all of the participants. If your picture becomes jumpy or out of sync, click stop video in the lower left corner, and that will help speed up your connection and make it stronger. For questions, and we really hope that you share a lot of your questions today, please use the chat feature that's right in the middle of the bottom ribbon of your screen. But please do not share or ask any personal medical questions, because everything that's in the chat can be seen by everyone that's participating in the town hall today. But we really want to encourage you, if you do have a personal medical question, to please reach out to your doctor directly. And we'll do our best to try to answer all the questions today. So with that, I'm going to introduce our speakers. Our first speaker today is Dr. Erica Shenoy, who is a MD and a PhD, and she is the Associate Director of our Infection Control Unit and has really led a lot of our emergency response to the COVID pandemic at MGH. We're also going to hear again from Dr. Matt Russell, who is the Clinical Director of the Geriatric Medicine practice at Mass General. And he's going to be talking about some of the things that are important for everybody to know about the geriatric medicine practice that also are very applicable to all of our primary care practices today. So let's get started. I'm going to hand this off to Dr. Shenoy.
Great. Well, thank you for having me again. And I just got a thumbs up that you can see my slides and hear me okay. Great. So it's great to be with this group again. I looked back at the slides that we went over, I think in September it was, or October, and I've updated them, of course, with what we know today, as of today, or this morning. And so I do want to make the point that I know some of this recording, some people may be looking at afterwards or reviewing it afterwards, and just to realize that it's just as fresh as today, and things are obviously changing very quickly. And I'll try to identify at different parts of the talk where the uncertainty is, what we know and what we don't know, and maybe some ideas about the likeliness of various scenarios. So this is my agenda, just describe the current state of the pandemic. I do want to raise, the comment that we are seeing other respiratory viruses this year, whereas last year was very abnormal and we didn't see a whole lot, but this year we certainly are seeing those, and what you can do to reduce the risk of those viruses. I'll go through the current COVID-19 vaccine recommendations. I'll touch a little bit on what we know about either Omicron or Omicron, whichever school of you're from in terms of how you pronounce it, because there is somewhat of a debate about that. And then I highlighted some of the questions. We went through some of these last time. There were some other ones that came across that we can go through, and there's certainly enough time to answer additional questions as they come up. I do want to reinforce what was already stated, that when you have personal, medical questions, that your providers are their best resource. And certainly if there are questions that come up here and I can help with those, I'm happy to, but just follow the instructions I think that we're given. So here are the trends, and this is I put the websites for all of these here. So if for some reason you wanted to look them up or bookmark them, you're welcome to do so. I check this one around 5 o'clock each day when they update it on the weekdays. And here what you're seeing in blue are the 7-day average of confirmed cases. And this is the start of the pandemic to date. And obviously lots of things have changed in terms of our testing and the availability of testing, which has increased over time. But you can see most recently, this big increase. Now, in the last couple of days, we've seen a downturn. Am I still being heard? Because it gave me a sign that I wasn't being heard. I'm good? Okay. So what I was saying is, if you look back around the same time after Thanksgiving last year, we saw a dip and then it went up again. I can't say if that's going to happen again, but there obviously are patterns of gatherings that happen between Thanksgiving, Christmas, and New Year's. So it's possible that this little decline we're seeing will go up and we'll see another increase, and then things will come down after New Year's and things get back into kind of the normal amount of socializing that people do. Now, there are obviously some question marks as to the impact of Omicron, and we'll get to that in terms of what this trajectory might look like. The other part in green here is the 7-day weighted average of percent positivity. And what this means is they take all the tests that are reported being done to the Mass Department of Public Health, and they, on the denominators, all those tests, and the numerator, all the positive tests, the new positive tests. And so we had gotten down pretty low in the beginning of September. We were below 2%, and we've been creeping up to about 5%. In orange is one of the things we'll talk about, and as it relates to how the hospitals are handling this and what that might mean in terms of elective procedures, which you've probably been hearing about in the news. But we are certainly seeing an increase in the number of COVID patients in the hospital across the state. And I'll go that into a little bit of detail because it's not as straightforward as just looking at the number in terms of what that means. And then lastly, the 7-day average of confirmed deaths. While you see it creeping up a bit, we have never gone back after post-vaccination. So vaccination started kicking in, right here in January of last year, or about a year ago, but really kicking in terms of full vaccination and the highest risk individuals for death. We have not seen the death rate ever come back to what it was before. And that is really a testament to the vaccination, the impact of those on those serious outcomes, to the availability of some therapeutics for patients. And obviously we have learned how to take care of patients over time. And I suspect part of this is just we do it better than we did in the very start of the pandemic. If you break down that percent positivity, because that's a number, but what does it mean in terms of age groups? And the reason I include age groups is because age is such a strong predictor of hospitalization and death. And so if you look here, there's lots of color coding here, but the ones to focus on first are the light gray, dark gray, and yellow, because those are the older groups. And those groups have really been on the lower side in terms of contributing to the overall percent positivity. The groups on the higher end have been maybe more active socially. It's the green and this light blue, so 20 to 29-year-old in light blue, and the green are the 30 to 39-year-olds. One thing that's really interesting, and I just noticed it when I was pulling these slides last night, they get them updated once a week or so, is that in the 5 to 9-year-old range, there is a tick down. And I don't know if it's too early to see this, but we have been pretty good in terms of getting those kids vaccinated as soon as it became available. And I'm hopeful that number will continue to come down. And that's because these kids are now protected the way their siblings have been. And if you look at that, this is the Massachusetts data. Again, this is updated once a week. So it'll be updated, it's a Thursday, right? So it'll be updated tonight. So this is as fresh as last week. Now, Massachusetts has done really, really well with vaccination. You may ask boosters. They are not breaking this down yet by boosters, but I can tell you that as of this report yesterday was the 15th, 1.6 million booster doses had been administered in Massachusetts, and our population is about 6 million. So we are doing really well with boosters, and we'll continue to push booster vaccination for the appropriate age groups. But here we're looking in blue at fully vaccinated, the teal is partially vaccinated, and gray is not vaccinated. And then they break it down by age, 0 to 4. Of course, there's somebody reporting a 0 to 4-year-old partially, and I'm not sure who that is, but it really, they shouldn't be. But here you can already see in the 5 to 11-year-olds, 35% have at least started their vaccination series. That's terrific. We already have some who are fully vaccinated because they got right in there, the weekend or the week after they were eligible. But in every other age group, we are meeting or exceeding the national numbers, and especially in the older age groups where our vaccination is really terrific. Now, all of these unvaccinated folks, that's so important because when you look at the hospitalization numbers, it's primarily driven by unvaccinated individuals. What about those breakthrough cases? So breakthrough cases is when you get a COVID infection after you've been fully vaccinated. So 2 weeks after that primary series of either the 2 doses of Moderna, Pfizer, or 1 dose of the Johnson & Johnson. And if you look at the cumulative numbers, so it's that last column, of all the fully vaccinated individuals in Massachusetts, right? There are a lot of us because you saw those numbers, what a good job we've done in getting vaccinated. About 2% of those individuals have gotten COVID since being fully vaccinated. A subset of those cases, 0.06%, have ended up in the hospital. And among those cases, those 2,966 cases, there have been 699 deaths due to COVID from those individuals. Or I don't know if it's attributable to COVID in that sense, but admitted and died from COVID. So now I'm going to pull back from those statewide numbers and give you a sense of what it's looking like in the hospital, because that plays into what you're hearing about elective procedures. So this is the full pandemic to date. And to orient you, this top bar are the total of patients that we have in the hospital at MGH that day. It's a census number. And the dark teal are the COVID confirmed patients, and the light teal are those that we're trying to figure out do they have COVID or not. They're coming in with symptoms, we're testing them, we're working them up. And you can see that in the early part of the pandemic. Remember, this is when Governor Baker said no elective procedures, we're closing it was very, very, we all felt it. There was a serious decrease in the services rendered at the hospital and people coming to the hospital. And so the gray, the total dipped quite a bit as we were experiencing that first surge. But in the time since then, our volume is bigger than it has ever been, in the sense that we are often every single day, I would say, minus perhaps a weekend day here and there, at very high capacity with very limited bed availability in our facilities. And if you zoom out and just look at the COVID volume as a proportion of it, actually, if you think about it, the majority of patients in our facilities do not have COVID and are not being ruled out for COVID. But if you zoom in on that group, you'll see that, yes, we are seeing an increase in our COVID volume here, looking at the most recent days. It says 12/11, but I pulled this as of last night, where we have about 114 total patients that were either working up or have confirmed COVID. And if you look deeper at those numbers, because people always ask, what's the vaccination status? And this has been reported in the newspapers, is that it's about 70% unvaccinated. The other part to mention is that for any patient admitted to the hospital who has COVID, has that diagnosis, there is a proportion of those patients who COVID wasn't the reason they came to the hospital. And you can imagine that number of patients who, for example, come in with a heart condition, or they have a fracture, or they're in a car accident. And because we test every single person when they come in, and we test them again on hospital day 3, we can detect COVID. And that person, had they not been in the car accident, may not have been diagnosed with COVID. So there are reasons other than COVID that people get into the hospital. I'm not minimizing the COVID at all, but I'm saying that not every person on this group, in this list, is actually here because they are suffering from COVID, symptomatic from COVID, or need any treatment for COVID. Now, what has this meant for elective procedures? Well, based on a requirement from the state effective as of yesterday, and there had been some initial towards the end of November, early December, trying to dial down some of the elective procedures. This is the requirement from the state that hospitals must reduce non-essential and non-urgent scheduled procedures by at least 50%. And the rationale here has been both that increase in COVID. So you see that absolutely we have more COVID patients in the hospital, but addition to that, severe staffing shortages. So that if you don't have the staff, even if you had a physical bed or an operating room for a patient, if we don't have staff to then take care of the patients after their procedures in the hospital, we can't continue to bring people in that scenario. And they've defined elective as non-medical, not medical emergencies, basically. So what does this mean for you if you have something planned now, a few weeks from now? I think the best bet is to just wait to hear, because the hospitals are going through and they're trying to figure out how to prioritize. And it's a very difficult thing to do, because what may be technically elective may not feel elective or truly be elective in a way for someone's quality of life or what's going on with them or everything they planned, to have this particular procedure at this time. So what I would say, and Matt may want to jump in here, but you'll hear from your providers if there's a change to any upcoming procedures that you have. And I just hope you could be patient on our side, because this is very difficult on our end. And I know that there are so many people who are doing their best to make really hard decisions and just ensure that when you do come to the hospital, we have the resources to take care of you and do give you the best care that we want to give to you and that we are used to giving to our patients. So I'm going to switch gears to the other respiratory viruses just to know that they're back. Last year, as I mentioned, was super abnormal in many ways. Part of that is because there were many restrictions in place. The schools were not, these are kind of some of the reasons that might play into this. The schools were not in full activity, but they're back. And this is what it looks like. So 2020 to 2021, as I mentioned, very abnormal year. And I'm just talking about influenza here. I don't have huge predictions for this year because it's a fool's errand. You cannot do it. And I'll probably be wrong if I say anything, but I think we can say that we are seeing influenza activity. And what I'm showing you here are some trends from December of last year to current. And the red here is COVID-19. And when I look at this chart of the 7-day moving average of cases, I have to take COVID out because just proportionally, these other viruses are much less common, but they're still there. And here are the trends. So again, December to current, I took COVID out of the picture. So I'm just going to be looking at some of these other viruses and specifically influenza in the dark teal. You can see that it was like flatline here, no flu, no flu, no flu, no flu. And then we start seeing the flu take off. And there have been a bunch of clusters around the country among college kids, and they're seeing influenza activity. The second virus that we're seeing is RSV. Now, you probably may have picked this up in the news. At the end of the summer, pediatricians started reporting we're seeing RSV again. This is a common kind of childhood sort of ailment. It can affect adults, of course, but since the end of August, we've been seeing RSV tick up, and it's there. Lastly, rhinovirus. This is the common cold. It kind of, in a weird way, never went really too far away. It was at low levels. You can see it in the gray, but it's definitely ticking up again. And these are all spread the same way as COVID, close contact through respiratory secretions. So what can you do? So make sure you're vaccinated for the flu. Not too late. You can absolutely get vaccinated for flu. The other piece is that there's testing out there for flu, but most places you're going to go get tested when you get symptoms, because flu and COVID overlap, is you're going to get your COVID test. So I would say if your test with COVID is negative, you feel good, I don't have COVID, but you should definitely check in with your provider if you're not feeling well, because you could have flu. And we have treatments for flu, and you don't need a positive test to be able to, if you're the right, depending on your risk factors, treat you for flu. And so I wouldn't just say, oh, COVID's negative, I'll just get through this. If you're not feeling well, I would definitely encourage you to talk to your provider about it, because it could be something else that we can do something about. Or you may need to come into the clinic, in which place they can test you for flu and COVID again at the same time. I'll switch to the COVID vaccine recommendations. So they're a lot simpler, I think. When we met before, it was like mix and match, and we didn't even have a recommendation for Moderna. At that time, it was only Pfizer. So primary vaccination, everybody age 5 and above. Because Pfizer's is the only vaccine for ages 5 to 17, that's the only one that group can get. But if they're age 18 and older, you can get any vaccine. Now the booster is recommended, and there's a lot of push to this. So if you haven't gotten boosted, I would strongly encourage you, depending on the timing here, to get your booster as soon as you're eligible for it. Based on the time, it's that you're recommended to get the booster. And the concept of the booster is that over time, the immunity that you have built from those first 2 shots, or if you got J&J that first shot, it will decrease over time. And many of our other vaccines that we get have boosters built into the course. In fact, some of these, when you're a kid, you get like the same vaccine like 5 times over the course of a period to like make sure that you get long-lasting immunity. So in this case, it's very reasonable to expect that a booster right now, we started talking about boosters as soon as the vaccines came out. When are we going to get boosted? So we are getting boosted now. And teens, this is new as of last week. They put this not in the should get boosted, but they allow it. And I think based on the way the CDC has been doing this, it's a matter of time before they will, put them into the group and say, you should get it, go get boosted. But right now it's more of a can if you want to for the 16 and 17-year-olds out there. Importantly, at this point in time, the definition for being fully vaccinated has not changed. I think that it probably will. I don't know if that's going to be early in 2022 or when it will be. I don't know what it's going to look like. You might imagine it's something like being fully vaccinated is you have your first primary series and you're boosted within 6 to 12 months or something like that, where that now consideration for fully vaccination includes booster, but we're not there yet. And as I said, I could be totally wrong. It's just kind of the way it seems like it might be going. One important point to note is since people are getting vaccinated everywhere, it's not just here at your doctor's office or in one of our clinics here, there's many options outside. You don't have to worry about calling your doctor's office to tell them you got it, because there's a download from the Massachusetts, basically Department of Public Health. They're basically uploading from wherever you got vaccinated your information, and then they push that information into our electronic health record. And so it's not happening immediately. Sometimes it takes a few days. I've noticed this for my own family members when I'm checking in Patient Gateway to make sure that they're all up to date on their, the vaccinations are all listed, but it does get there eventually. So don't feel obligated to call and let them know and tell them that you got boosted, or you got vaccinated, you're all set there. So that's good to know there. Okay, Omicron or Omicron. Again, this could be outdated as of midnight last night, or the last time I put some references here in the slide. So I'll do my best and just know that we're learning a lot, just like we learned a lot from the prior variants as they made their way. So the history of Omicron is that it was initially reported, this is right at Thanksgiving. It really spoiled some of the Thanksgiving discussions because that's what people were talking about, but came around on the 24th. And actually it was detected a couple weeks earlier. So on November 11th in Botswana and then 11/14 in South Africa. A couple days after WHO was notified, based on a look at a couple things, mostly related to the number of mutations in this variant compared to prior variants and the original strain, they classified it as a variant of concern. And there's certain categories. You can be a variant of interest. You're not too interested. You can be a variant of concern. There's some things that we need to be looking at. And then there is the kind of higher category, which we've never had a variant, where they're very worried about it. So that category has not been reached. But in any case, they called it a variant of concern, or a VOC, on November 26th. And then the CDC followed suit 4 days later. And our first case in the US was on December 1st. Now it's been reported in many countries all over the world. What I'm showing here in the top map is anything in the yellowish color is where it's been reported. If it's in a dark yellow, like the mustard, that's where there's local transmission. In the other ones where it's the light yellow, they've mostly described imported cases, travel related, but really, I think nobody is going to say it's travel related at this point. It's really going to be being spread in our communities, just the way Delta was. So there's an initial period where travel might be important for any of these variants, but if it is able to spread in the community, it will happen, and it's just a matter of time. And certainly that's happening here in the United States and Europe and other countries. Now, as of early this morning, it was in 35 US states. We're doing robust surveillance. So as an example, all the positive samples obtained at Mass General labs and some of our other labs in our system, they get sequenced. And we've been sending that information for months to the Department of Public Health, and they pull those data together. They're sharing with the CDC so that we are doing surveillance all the time, basically, for variants. And on one of the tests that we do here at Mass General, there is a failure on the test, not to detect COVID, but it has a specific name. And when that happens to a sample, we bump those up in the line for sequencing because those are more likely to be Omicron. So we have a process in place where all these data are getting fed to the Department of Public Health, so they have a better sense of the dynamics here. And I'll show you what we know about that in the next slide. So why would it be a variant of concern? Because it has more mutations, and it has mutations in important parts of the virus that then theoretically would have implications for whether or not it's going to spread easily, whether or not our vaccines are going to work as well as they did in the past. Now, right now, if someone were positive in Massachusetts, you could bet your money it's most likely to be Delta, just because we have more Delta right now. What the balance will be, will Omicron just totally displace Delta? Because remember, last spring, we didn't have very much Delta. We had Alpha. We kind of skipped, we didn't get too much Gamma or Beta, and then Delta kind of swept through. And many are thinking that Omicron will sweep through and potentially replace Delta. And we'll talk a little bit about what that might mean. But right now, as I mentioned, a lot of sequencing going on, doing a lot of surveillance here in Massachusetts, around the country and around the world. So these are data, they have not updated them as of 5 days ago. So they do it on a weekly basis. They're collecting the data, but then they summarize it. And this is describing what the proportion of the various variants are across the US by region. We're region 1, New England region. And the orange color is the Delta strain. So you can see a majority are Delta, but in the New York and New Jersey region, where you've got region 2, it's 13%. And so when they publish this on Sunday or whenever a week, Sunday, or maybe they'll update it sooner, those purple wedges are going to be bigger. And if they completely displace Delta, then what will be out there will be Omicron. It's just too hard to tell at this point, the pace at the displacement, if there will be still a little bit of Delta left, it's really hard to say. I think many people are guessing that the way Omicron is displacing Delta in other countries, that it might do the same here. Now, every country is different. Some of the countries, for example, in South Africa, where it quickly took off, they have 25% of vaccinated population. So, there's so many different things in play as to how this is all going to end up, but you have the website here. So if you ever wanted to get the up to the minute information, you could take a look, but I'm sure you'll hear it in the headlines as to when we become if we're still Delta or if we're Omicron. So the big question about Omicron, these are the ones we ask about every variant. So when there is pi after Omicron or whatever the next Greek letter gets assigned a variant of concern, these are the questions we'll ask. Is it more transmissible? And I think right now, with the limited information we know, it is likely, some people are saying very likely, as it is accounting for an increasing proportion of cases. Now, there has been some question, if you're selectively sequencing, are you just going to pick up more Omicron and maybe that's driving it? But I think many people believe that it is more transmissible. And there are some kind of science studies where they're trying to account for why it might be more transmissible as to where it replicates, the amount of virus you produce. But I think in this case, it's probably going to be more transmissible than Delta. And Delta was more transmissible than the other variants before it. Now, the big one question is, it could be more transmissible. Does it cause more severe disease than Delta? And in fact, remember when Delta started, everyone was thinking, is it more severe than the other one? And at the end of the day, as much as we know about Delta now, it doesn't seem to have been more severe. Certainly more transmissible. So more people are going to get it. And the more people who get it, you may have a subset who experience severe disease. But actually, Delta didn't cause more severe disease, at least as far as the literature shows at this point. So we don't know about Omicron yet. These are kind of bigger studies, but some of the earlier reports coming out this week suggested mild disease. But you can have delayed hospitalizations. And if I give the example of South Africa, their population may be mostly unvaccinated, but the groups that were initially affected were quite young. So it's hard to say whether or not it will cause more severe disease. There was also another study published, a larger one, showing that it was quite protected, that people who were vaccinated were still quite protected against hospitalization. So we'll have to keep an eye on that. And that gets us into the next thing, which is, are those mutations, those 30 plus mutations, such that if I got COVID naturally, am I likely to be reinfected? Or if I'm vaccinated plus boosted, will I be protected? And so there are a bunch of different studies, and some of these are done in the lab in a little, in addition. Others are epidemiological studies where you're looking to see what happens to people who are admitted to the hospital, looking at their vaccination and their booster status and trying to make assessments of how protected people are. The preliminary studies, when they look in the lab, they show that the antibodies that attack the virus are lowered. If you compare the way your plasma, your blood would react to the Delta strain or other strains. So when it is reacting to Omicron, you have reduced what they call neutralizing antibodies. That does not equate with vaccine effectiveness. So when those headlines came out that said 40% reduction in neutralizing antibody, people were saying, oh my gosh, it's 40% less effective. That is not the way to interpret it. But these studies also showed that when they looked at the blood of individuals who got the 2 doses and then got boosted, that the amount of antibodies that were protected actually equated to 2 doses to Delta. So maybe it's 3 doses to Omicron, 2 doses to Delta. That would be okay, right? Because we have the tools with us, we have the boosters available to do that. Again, the caution is that vaccine effectiveness in the real world today, what is the likelihood that I, fully vaccinated person exposed to Omicron, will develop an infection? If I get an infection, will I be severe enough to go to the hospital and have a bad outcome? That is really not well known. There is one report, a study, actually quite a large study, where they're saying that the protection from the vaccine preserves your protection against hospital admission. Now it's less than what it is for Delta, so it's 70%, but still quite good in terms of protecting you against getting hospitalized. Now, what about those monoclonal antibodies that have become, you hear a lot about those monoclonal antibodies. Some of you may have received them both for treatment or for prophylaxis to prevent if you have an exposure and you're at high risk. Now, these, there is research ongoing, and it's most likely that of the kind of various ones that are out there, some of these will remain effective and some of them will have less potency. And we just have to sort out what the end guidance is going to be about. At this point in time, if Omicron takes over and it's all Omicron, then there will be certain ones that you can use for that. If there's a mix of Delta and Omicron, we're just going to have to figure out which one to give people and go from there. I'm just going to give you, do not read this table. It's an example of how, for example, the WHO is looking at alpha, beta, gamma, delta, and Omicron. And on various parameters, kind of what we talked about with different vaccines, trying to say, what's the vaccine effectiveness? And the point is, there's no evidence yet. We just don't have enough information. We're getting that day to day. But I do want to recall, and this is something I showed you before, at least to Delta and the variants we'd had before, all the vaccines that were currently authorized were effective at severe disease, hospitalization, and death. Now, with each subsequent variant from the wild type, there has been lower effectiveness against getting infected, like asymptomatic or symptomatic. But the hospitalization part, the part that really, if you think about it, we're all used to pre-COVID getting colds. It becomes a real problem when you end up really sick and in the hospital and die. And so that's a really important endpoint. And across all the studies to date, and these are not updated with Omicron because those studies are kind of in the works, the efficacy at each subsequent variant was still maintained. I'll go through a litany of questions. I know we're going pretty long here, but there's many choices to get vaccinated, so that should not stop you. They can even come to your house and give it to you there. Questions, which booster should I choose? It is really up to you. I had a relative kind of try to push me. They were Pfizer, should they get Moderna? They were Moderna, should they get Pfizer? I said, I'm not going to tell you what to do. Just do what you want because the data here are kind of mixed. And there were some studies saying the Moderna was a better booster than the Pfizer. And I don't think it really matters. I think the point is you get boosted. Will you need another booster? I don't know. I think if we're still in this phase where COVID is whatever variant Pi or whatever variant is out there next is causing challenges to the healthcare system and people's health, then it's reasonable to expect that there might be a time at some point in the future when our immunity is waned or the variant has modified a bit, that booster might be needed, either the same booster as what we have or a different booster. And with kids under 5, they're working hard on this. I mean, obviously that's the last group to get to. And I don't have an inkling as to when they're reviewing those data, but I would expect it went pretty quickly with the 5 to 11-year-olds. So maybe we'll see something in early 2022. Now there's lots of different risks of activities. I didn't change this slide much because it kind of stays the same. And I do like to highlight that it's the holidays. We want to spend time with our families, do normal things. I think there's a real urgency for all of us to try to find some sense of normalcy. And what it ends up coming down to is your own personal risk assessment and that of your household. Because most transmission, again, is going to be happening in households. That's where most of it happens because of our close contact with each other. And so the question is, there's lots of different risks of exposure depending on where you're going. And just assume that there's community prevalence out there, like you saw the numbers. And then you have to think of, if I get exposed, what's the likelihood I'm going to get infected? If I get, and that's vaccination, booster, that sort of thing. If I get infected, what's my risk of severe disease? And that might be underlying conditions, how old you are. If I get infected, say like I got infected, but my risk of severe disease is quite low. What does it mean for others in my household? If there's someone in your household who is at high risk of severe disease and I expose them, then that weighs into my calculus. And are they at risk of severe disease? If I get infected, I expose them and then they get sick. So there are these multipliers that you have to think about. And in the end, you make your own decision as to what you're going to do. I think travel is all about who you're with. I think travel can be very safe. There's no increased signal around planes or anything like that. We talked a little bit about gathering with your family. The primary way to reduce risk in that sort of situation is to ensure that everyone who can be vaccinated is vaccinated and boosted. Dining out is really about who you're dining with for the most part. And then, mass indoor locations, you just have more chance of coming into someone who might be coming in contact with someone who's infected. And you can kind of do your own personal math as to what you think about that in terms of your own personal and family risk. The mask mandate has not changed. It remains in there's no public mask mandate for Massachusetts. There are some calls recently to reimpose that. The exceptions are very clear. Schools, healthcare facilities, public transports, have not changed. And then they really recommend as part of the advisory that the unvaccinated wear masks. And then if you're vaccinated, but again, you yourself are at increased risk from COVID-19, having a severe outcome, or you live with someone at increased risk, then you wear the face covering to protect yourself and those who are at highest risk, which is your household. Now, cities and towns have done their own thing, businesses have done their own thing, and you yourself can do your own thing in terms of masking. And then I try to keep it all in perspective, and I'll end here, is that vaccines are safe and highly effective. They really are. If you think about the flu vaccine each year, and I'm not poo-pooing the flu vaccine because I want everyone to get the vaccine because it does good. It's usually in a good year about 50% effective. But even if you get flu with the flu vaccine, you're at reduced risk of hospitalization and death. And so we have vaccines that are operating over 70% higher. Those are great vaccines. And we just have to continue that piece of this, the vaccination, and then layering different strategies and being vigilant. But we also need to put our own risk and the risk of our families and try to think about how we integrate normal activities. And that's a really hard thing, especially after 2 years of what we've been through, but it's part of the process of kind of moving forward. And I will just stop there and see what we've got in terms of next steps.
So I think we have an extraordinary number of really excellent questions. So Dr. Russell, if it's okay with you, I think in order to try to get as many of them answered as possible, we'll just go straight to the questions. Is that okay?
Absolutely.
Okay, so the first one that came in very early is, can you say a little about what the rapid at-home COVID tests are detecting, and did they also detect Omicron?
We think that they do. So certainly there's no concern right now about PCR-based tests. I haven't heard any concerns about the antigen tests. Now, I would say that not all antigen tests are created equal. Some of them have pretty poor performance. The one that seems to have, and I have no commercial interest in any of this stuff, I'm just following what is reported in the literature, is that the Binax now has the best track record, but there are others out there. So right now, there is not a concern, at least at this moment in time, that there's any decrement in terms of detection from the tests that we have available. It's not going to, none of these tests, none of them are going to tell you if it's Omicron or Delta. That's a sequencing sort of thing that is not part of a record, but they should work.
Okay. Another question, and I think you may have answered this, but we have a question about if you're immune compromised, should you be thinking about getting a fourth shot?
Yes. Yes. So if you're immune compromised, you should have gotten 1, 2, your third, which basically gets you into the primary vaccination series. And then 6 months after that third, get your fourth. And I think based on the timing of when all these approvals went through, some people are getting close to being at that 6-month mark for their booster.
Okay. So another question is, if someone got their the booster shot in mid-August, should they be thinking about getting a fourth vaccine early in the new year or just wait?
I would wait. We don't know when, unless you're one of those immunocompromised groups for which a fourth shot is recommended, I would wait to hear what the recommendations are going to be for 2 boosters, which is essentially what you're asking. So I would wait.
Okay. Another question is there any data about how long out from the second vaccination, not the booster, but the second, people are developing breakthrough cases? Do we know anything about that?
Well, you mean how long after, like, basically, I think what is being asked is how quickly does your immunity wane so that you're at higher risk of breakthrough?
Yeah.
There have been studies that looked at that. I don't have hard data right in front of me. The Massachusetts data doesn't really give you time since. The longer you're out there, further out, of course, it's going to be, but I don't think there's a cutoff after which, it's very clear. Now, there was a study published last month, and what I can do is I can put it in the, I can follow up and send it out, where they compared vaccine efficacy of Moderna, Pfizer, and I think the J&J, but it was against a positive test or symptomatic disease. It didn't look at it didn't look at hospitalization or death. So I'll come back to that, but generally, the longer you're out, your immune system naturally wanes, and so the timing of that 6-month period is meant to kind of balance, when is the right time to get it, and probably no one really knows. We make somewhat of an educated guess based on the totality of the data that we have.
Okay. I'm going to actually give the next question to Dr. Russell. And this is about our staffing. Dr. Shenoy mentioned that some of the reduction in elective procedures and other things is related to the fact that we're understaffed. And I can say that pretty much every healthcare organization in the country right now is understaffed. But can you say anything about what MGH or Massachusetts is doing to hire more staff?
Yeah, I think the important thing is that while staffing is definitely one part of it, there's really a multi-pronged approach. And, every health system in the country, and you're absolutely right, any of us who are on national meetings, we're all hearing the same thing. This is not a unique issue for Boston. Healthcare has been stressed, not only because of COVID, but for a lot of delay in care related to COVID, a lot of mental health challenges related to COVID. And so one of the things we're trying to do is, in addition to recruiting staff, like we've just hired another physician in our practice, we're hiring a second nurse in our practice. We recognize that the need is there. And at the Department of Medicine level, all of our practices, specialty and primary care, are working on enhancing access for patients so that any of the delayed care or the care that was deferred for routine health maintenance and screening during COVID, that there's now opportunity for you to meet with your doctor. The other thing that's very important for us as healthcare providers is to be able to be with our patients in the room in real time. We have this wonderful thing called Patient Gateway. It is both wonderful and horrible. It is horrible in the sense that it is a text message chain that can very quickly become completely full and overwhelming for the practice to manage. And so you will be getting from each of the practices, you will all be getting just sort of a how-to for Patient Gateway in terms of what to expect for non-urgent issues, how to address urgent issues, and what would expect in terms of a response time. So staffing, communication, diverting patients, and also we're doing partnership with our community affiliates. So I hope that made some sense.
Yes, and can I just ask you to say a little bit more about the gateway messaging about delayed prevention and screening testing?
Right. If you come across in your gateway message that there is something that is outstanding, meaning you're due for a vaccination, like a tetanus vaccination or a colonoscopy, please book a visit with your provider, especially in geriatrics. Computer-generated reminders may not be appropriate for you, particularly because of other considerations. And it's a discussion with your provider, and it's a real-time discussion. So please definitely book the appointment. And when you do send a gateway message, we respond in about 3 days. I think sometimes what happens is we'll all get in the habit of this is just like a text message, only it isn't. And we want to make sure that, in the days that I'm in the office seeing my patients, that I'm actually able to spend my time with the patients, not doing a backlog of computer communication.
Yeah, and just to add a little bit more to what Dr. Russell just said about the messaging, also keep in mind that that's for the business working days. So the 3-day response does not necessarily include the weekend. And one of the other things we're seeing is that people do kind of think that sending a message through Gateway is like a text message. And if they don't get a response quickly, they will call the practice, and that just continues to add to the to-do list for very short-staffed practices as well. It's not just in the inpatient setting. So the more that we can do to kind of support each other and help each other during this time, it is really deeply appreciated. And obviously, if you have a very urgent question, it's important to call the practice. So another question that has come in that I think is really important, because as things started to open up a little, More indoor performances were happening. It's the holiday season. There are a lot of opportunities to do things. So Dr. Shenoy, can you say a little bit about any sort of guidelines about going to an indoor performance? What kinds of things should you be looking for? You know, I know for me, I've gone to an indoor performance where you had to show your ID and your vaccine card, and everybody had to be masked. And if anybody let that mask slip, somebody came and talked to them. And that made me feel safe. But can you say a little bit more about what people should be looking for if they're thinking of going to an indoor performance, and what kind of questions might they want to ask ahead of time?
Sure. And I just wanted to emphasize that part about deferred care and catching up on it. One of the reasons, and it relates to one of the other questions about how we're at so high capacity, is we're seeing people who didn't get care during the pandemic and they're coming in later in the course of the illness. So please do that. It's really important to catch up. So about indoor performances, what you described is what a lot of people are experiencing when they go to indoor performances. There's a requirement for vaccination, or I know this from a family member who took a child under 5 to the Nutcracker, and they required a test that day, a rapid test that day, or a PCR within the prior 3 days. So sites are making these sorts of interventions, and right, you can't be sure that no one's faking it, or faking a test, or showing the wrong thing. But in general, I think it does impose a barrier for the people who want to go to these events, that they are generally vaccinated or tested that day. And the addition of the masks in the indoor environment, it's certainly what you described sounds quite safe to me. Part of our thought of risk is really colored by the fact that we hear about the super spreader events, and there's social and gatherings happening all the time. And we hear about when things go wrong. And usually when things go wrong, there's a lot of factors at play, not just one thing that went wrong. There's many, but in a case like you described, vaccinated or tested, masked, good compliance with that, it seems to me to be perfectly reasonable to go to an event like that.
Great. One other question for you, Ray, the testing, and that is, can you say a little bit about PCR testing and that picking up Omicron?
Yeah, so PCR tests are going to pick up any of the variants that we've identified. They're not going to tell you which one it is. That's what the sequencing is for. So the sequencing that's done in research labs at the public health, it's not part of, it's not going to be in your medical record that you have Delta or you have Omicron. There is, I mentioned this, there's many different PCR tests out there. We have, I think, 6 that we're using at MGH right now for various reasons, but one of them will have it'll tick off a thing called a gene failure. It doesn't mean that it didn't detect COVID, but in the COVID it detected, it saw something odd. And that's the same thing that it saw for the Alpha variant. And that's the tip off that it could be Omicron. And those ones is what I mentioned. We prioritize those for sequencing. I mean, we're sequencing everything, but those are the ones that we put kind of at the top of the list. But you're not going to be told by your provider if you have Omicron or Delta. It's not worth asking at this point. There's no actual consequence in terms of any clinical outcomes at this point. In the future, if it mattered for monoclonal antibody choice, then there would be a need to know what it was. But at this point, it's totally irrelevant.
Okay. Can you say anything? We have a question about how do you determine the degree of immunocompromisation? I can't say it, the word, that would warrant additional boosters, for example, low dose methotrexate for RA.
Yeah, so there's a list. And we, the CDC came up with a list, and it's pretty clear now. We at Mass General, we kind of looked at that list and we gave some more specifics around dosing of these, because the CDC can't cover everything, and they really do leave it up to a discussion with you and your provider. Every patient is a little different. There's obviously some very obvious cases of transplant patients or things like that. But if you look at that list and you have a question, I would talk to your provider about it. And get a sense of what they think. And they also, primary care knows they can reach out to infectious disease or our immunocompromised service and ask us questions, and we're happy to weigh in if there is someone who is borderline and you're not sure.
Okay. Another question that's really a clinical question is, can you say anything about how we might be thinking for people that don't have severe COVID to get care at home, to help decrease the inpatient need and also perhaps the need for people coming into the emergency department?
I love that question. It's something that even outside of COVID, we could do really well, and we could deliver care in the most appropriate place. And so I think that came from Jackie. There are efforts here to replicate some of the really successful models and try to keep people out of the hospital when possible. I think that we have more tools that we had in this surge than we did before in terms of prophylaxis for high-risk exposures or delivery of monoclonal antibody that now I've been hearing is now being done in the home for some individuals. So I think that there's lots more to do in that space, and it's a great question and something where people are working on, not me specifically, but teams of people are working on.
One last question is, can you say anything about what we know about the possibility that Omicron will also result in sort of long haul COVID?
I can't say anything. I don't know. Too early to tell. I mean, Omicron hasn't even turned 1 month old.
Yeah.
Oh, wait, actually, yes. If it was found on the 11th, we're 1 month into Omicron.
Yeah.
So we'll
Yeah.
find out more in the new year about that.
All right. Well, we're almost out of time, so I'm going to give the last word to Dr. Russell. Is there anything else you'd like to add?
I would just like to thank Dr. Shenoy and Susan for a wonderful presentation, and also for our attendees for really wonderful, wonderful questions. Thank you for your ongoing support in this program. We are going to continue this in 2022. I think, as I said earlier, we'd love this to be in the rearview mirror, but until it is, we're here for you. So happy holidays to all of you, and stay well.
And as Dr. Shenoy just said, thank you for attending, and let it be a happy new year. So take care, everybody. Please stay safe.